Hello, everyone, and thank you for joining today's webinar. Just a few housekeeping notes before we get started. All of the participant microphones are muted. Make sure that your internet connection is on full, and if you have any technical issues throughout the webinar, feel free to use the tech support chat pod on the right side of your screen. And for any questions for the presenters, we will have an opportunity for discussion at the end of the webinar. But if you have questions throughout, please feel free to put those into the presenter Q&A pod, and we will address those at the end. So thank you for joining today's webinar, Leveraging Health Information Technology to Advance Health Equity. I am Megan Douglas, Associate Project Director for Health IT Policy in the National Center for Primary Care at Morehouse School of Medicine. And we have the Georgia HighTech, which is also a project here in the NCPC, who is co-sponsoring this webinar today with us. The TCC and this webinar are funded by the National Institute for Minority Health and Health Disparities. This is the disclosure statement for that. And just want to add, too, that we are not endorsing any products today, just providing a platform to provide some examples of some great work that's happening in this field. The learning objectives today, we will be discussing some specific examples of health IT being leveraged to address disparities, and we'll have an open discussion at the end where we'll talk through some policy and practice facilitators and barriers to moving this field forward. So we are having this webinar today for National Health IT Week, which is running this whole week. And we are really excited to have this opportunity to use this week to talk about how health IT advances health equity. There's a lot of work going on in this field. Sometimes it doesn't get that same level of awareness as some of the other exciting health IT things that happen. So this was really an opportunity for us to make sure that that conversation is being had. We are also in the midst of launching a video series on the issue called Closing the Gap, Leveraging HIT to Advance Health Equity. And we are doing a lot of promotion on Twitter. Please follow us at PCC_HIT policy and use the hashtag HIT to equity. And you can see all of the videos on our website under the videos tab. So before we get started with the presenters, I want to talk a little bit about the TCC Health IT Policy Center. As I mentioned, we are housed in the National Center for Primary Care here at Morehouse, and we are one of the sub-projects of the Transdisciplinary Collaborative Center, which spans a number of different departments across Morehouse. And we have two primary components to the work that we do here, one being the research. So we are studying policy and practice implementation to inform policy and inform practice on the impact of health IT policies on health disparities. And we also do a lot of coalition building. So we have built really, initially we were looking at a region-wide coalition, but now that we are over 4 years into this project, we are really looking at more of a nationwide coalition of health stakeholders who work with us to evaluate the policies and inform how those policies can better impact and improve health disparities. So just a short glimpse at some of the research that we've done. We did an analysis of the Meaningful Use program and found that there was a gap in the type of demographic data that physicians collect under that policy, under that program. And we published that paper in the American Journal of Public Health. And in the last stage of rulemaking, Meaningful Use Stage 3, we saw some of those policies change to better collect more meaningful data, granular race and ethnicity, sexual orientation and gender identity, and 8 different domains of social, psychological, and behavioral health data. And then soon to be published, coming out next month in the online version of Psychiatric Services. It'll be published in hard copy, I think, in February. We did an analysis of Medicaid claims for telemedicine utilization and found that overall the utilization for 2008 and 2009 was relatively low, even though Medicare reimbursement had been around for 10 years at that point, and a lot of states had been reimbursing for a number of years. And we also found that the predominant use of telemedicine was for behavioral health treatment. So you will get more details on that study once it is published next month. And I am really excited today to have the panel of speakers that we have. They are each going to be talking about some very different topics, but they all come together under that intersection of health IT and health equity. So we have Dr. Dominic Mack, Director of the National Center for Primary Care. He is the PI of the Health IT Policy Subproject of the TCC. He is also the PI for the Georgia HighTech, the only federally recognized regional extension center here in Georgia, and he'll be talking about the work of the Georgia HighTech. We also have Marquesa Finch, who is co-founder of P2 Health, and Eric Connor, who is CRO and co-founder of Healthify. So they will be sharing some of their work with us and how it impacts health equity as well. So I will hand it over to Dr. Mack, who will start us off.
Thank you, Megan, and thank you all for being here today. As we celebrate HIT Week, I think this is appropriate to talk about innovations in healthcare, especially when it comes to health equity and health disparity. Always like to keep things patient-centered, and I want to start with just some information that American Public Health put out a little earlier, I think over the last 2 weeks. An article about when wealth determines health. And what the article talks about is higher incomes are synonymous with better health. There's a significant gap, 14-year gap between women who are the richest 1% and the poorest 1%. And when you come to men, it's about a 10-year gap. So the issue is with poverty and other determinants of health, there's a lot to be done. At least 44% of the children in the United States in 2014 were below the poverty line or just above it. So when you talk about health and when we talk about health information technology, what we're trying to get across today is the fact that we need to develop these products, these tools, this technology for the underserved communities to eliminate these gaps in health equity. And that's going to take more patient engagement and more development for those underserved, those practices, hospitals, and other entities who serve in underserved. But as we look back in HIT Week, we started this in 2009. And in 2009, if you remember when you went to your provider, it was a paper record that they thumbed through. If you go today, about 70% of practices and about 100% of hospitals will have electronic health record and other health information technology. And that's because of the spur and the impetus and the kick that we got from the HighTech Act that came under ARRA. You've heard of the Meaningful Use programs, the Beacon communities, the workforce development that has gone across this nation that has really sparked the creation and the development of health information technology. So to tell you a little bit about Georgia HighTech, which is one of the regional extensions, the 62 regional extension centers across this nation, but mostly just want to kind of focus on that portion of the program in this segment. These regional extension centers have really helped with this, the encouragement and the education and training and implementation of technology in these small practices and with the small hospitals, and mostly providers and all providers in Medicaid and Medicare. We've had partners within the state of Georgia that's helped with this. We've really partnered with the Department of Community Health um, from the beginning with the HIT plan and the HIT division there. I want to say happy birthday to them. Department of Public Health we're doing some work with now. And here at the school, as with the TCC, the Satcher Health Leadership Institute, and many partners across the state, academic and also community-based organizations. So we've helped over 4,000 providers in the state of Georgia, over close to 200,000 providers across this country. Georgia is a big rural state, and we have 56 critical access and rural hospitals, and we have more counties than any other state except Texas. So there's a need for these hospitals and these rural providers, and we've actually reached 100% of helping all the providers to adopt meaningful use and to qualify for Medicaid and Medicare incentives since the beginning of this program in 2009. We've done some research on the work that we've done here in the state of Georgia, and we found, as I've alluded to earlier, that there are disparities not only in health and healthcare access, but also access to the technology. And here we are today. We found that providers who had high Medicaid populations and those in smaller practices and some of those rural health centers adopted at a slower rate than those providers who serve mostly in privately insured populations, etc. So we have the disparity because of wealth. We have the disparities because of race and other issues. And also this is going over into how we adopt the technology. Everybody's better adopted, but there's still disparities in the innovation as we adopt it. So today we're here to kind of give you some tools that we're developing to try to help with these disparities. Another thing that we've done, and you've seen the development of health information exchanges all over the state of Georgia, and we've expanded into developing Georgia Health Connect here in the state of Georgia to not only the implementation of electronic health record within the underserved communities, but can you imagine if we can help these smaller practices and hospitals to exchange the information, but also develop cloud-based analytics and reporting that can help them to qualify for this new macro world that we're about to enter. We found also across the Southeast, especially we're working with FQHCs, that there are also disparities in adoption when it comes to health information exchanges. They're mostly highly functional in those larger health systems, but we have to make sure as we continue to implement that we can help those, again, those underserved communities. So there's still a lot of work to be done in that area. So, and I think this is my last slide, but the development of all these tools that we've talking about, the work at Georgia HighTech, the Health Information Exchange, the Georgia Health Connect, some of the tools you're going to hear about, we're trying to prepare these practices for macro, which we know is coming, and that's outside the scope of this presentation to explain macro to you. But the technology can really help providers in two of the areas and the components of macro, which is advancing care information and quality. It really helps in all four of the areas, but these are the areas that we're kind of focusing on today. So as we move forth, and macro is slowly, not slowly, but is fast approaching, we want to make sure that we're helping these practices that serve the poor, that serve the underserved, to implement this technology with not necessarily low tech, but tech that is affordable for these providers. So I'll pass it on at this time, Megan.
Great. Thank you so much, Dr. Mack, for that presentation. And we will hand it over to Marquesa to talk about P2 Health.
Thank you. Well, thanks for having me. I'm really honored to be here to talk about what we're doing, to be part of this conversation. It's extremely important. in healthcare today and where we're going in the future. So I just want to introduce P2 Health to you guys. So we are an incubator and a fund based out of San Francisco, California, and we are supporting and funding public health tech companies. And so we are defining public health as companies working in population and preventative health. And so we work under four verticals, one being p2health.lab is what we're calling it, and that is the incubator part. p2health.vc is our seed stage fund. p2health.edu is our educational arm. We do a lot of events bringing together the ecosystem around public health and tech, and it's largely to talk about the current topics and issues and trends seen at this intersection, but it also is to educate the various stakeholders on how they could be helpful and where the innovation lies within this intersection. And so we do a lot of education for would-be entrepreneurs on how to break into the entrepreneurial space. We educate a lot of venture capitalists and other investors about what the public health tech space is. It's a pretty nascent tech niche within digital health. And on top of that, digital health is pretty new compared to other tech niches. So there's a lot of education to be done across the board. And then the last vertical we work under is p2health.pub. And that's our research arm. We do a ton of research around this intersection. We also require that our incubator companies do pilot studies. And so all that data that's coming through either our incubator or our fund, we want to make accessible to the public. So we're doing that under p2health.pub. Now a little bit more about our investment criteria for the type of companies that we're looking for. It'll give you a better understanding of exactly the type of digital health companies we're looking for. So like I said, they must be working in population and preventative health, and they also must be closing some sort of health and equity gap. They must be committed to evidence-backed research, and they also must be committed to diversity within their teams and within the populations that they're serving. Excuse me. And so one of the biggest things that we do, in addition to many other things, is connect the capital that is heavy in Silicon Valley and California to innovation that's happening all over the country. One of the things that we're known here in the Valley is to have a lot of capital and a lot of investors that are willing to fund new ideas, experimental ideas. We've found through P2 Health, through our expansion to other states and cities, that the culture of investing is very different depending on where you are. And so Georgia, Atlanta is a space that we've branched out to and that we've been developing for the last 3 months. And we've noticed a difference in investment culture out there. Investors are a little bit more used to investing into health IT, for example, but want to learn more about what it's like or how they can invest in population health and preventative health and the health of communities. It's a different space for, I think, a lot of people throughout the country. And so we are connecting a capital-heavy state area, which is Silicon Valley, with the innovation happening all over the country. So that's one of our fortes in that respect. And in addition to that, we do cultivate the investment communities in these other states and cities as well, and connect them to the ecosystems around the country. And so then going back to what we do in the actual incubator, for those that are wondering, and I'll back up and sort of explain what an incubator and an accelerator is for those of who may not be used to the terms. Incubators and accelerators help seed stage companies scale and get connected to capital. They could also do some product development, but it's mostly about just growing the company to get them prepped for the next round of investment. And then they also connect them to a very curated set of investors who understand what they're doing and are interested in investing in the space. So that is what we are for public health tech companies. And within our incubator, we work on a bunch of different things, including business strategy, positioning, marketing, customer acquisition. These are all very traditional scaling training that companies need. But then we also get down into the nitty-gritty about what a specific public health tech company might need, including healthcare delivery and reimbursement. Pilots is a big thing. As I'm sure Eric can touch on later in the discussion, if you work in digital health and you have a new tool, you must have some sort of evidence backing up the efficacy of that tool if you're going to be successful in scale. So pilots and research is a big thing with us. We also touch on interoperability and tech standards, and then very important regulations, compliance, and guidance, which, believe it or not, a lot of early stage tech entrepreneurs don't have a great handle on when they first start. They're learning as they're going. Some may come from the health space and may know it already, but a lot don't. And so for us to have this component is really important. And so what exactly is the problem that we're solving? What is the opportunity? So digital health is actually more new than improved. It's actually one of the more, it's one of the newer tech niches compared to like finance tech or education tech or social. And although it's grown tremendously, and it's only going to grow more, it's still a nascent tech niche. And then if you're talking about public health specifically, it's even an even more nascent niche within digital health. And so what we're seeing is that the healthcare system, although moving more towards preventative and population care services, the tech hasn't exactly caught up to that, still focusing more on tertiary care. And so when we're talking about the opportunity to build tools within prevention and population health, we're talking about a $260 billion opportunity. This is how much we lose economically every year due to prevention costs due to lack of prevention. And so to the extent that we can use that as an opportunity, a market opportunity is going to be beneficial not only to how much we spend, but to our outcomes. And so we're looking at outcomes. We see that we spend about 90% of our spending is on access to care, but access to care only really accounts for 10% of total outcomes. Also, about 3% of healthcare is spent on prevention, but that lack of investment in prevention is costing us about 75% of the dollars that we spend. And so we really need to be thinking about how we're spending money when it comes to distribution of services and prevention and population health. We need to be focusing more on making sure people don't get sick instead of waiting until they do. And so some of the factors driving that opportunity, we have an aging population that's living much, much longer. We have incredible amounts of healthcare costs, earlier onset of chronic disease in millennials. This is something that we're seeing. About 35% of young adults have diabetes that's undiagnosed. And so, to the extent that we can focus more on living healthier lives, which is prevention, and thinking about the health of communities, and even maybe what the opportunities for precision medicine are for communities, we're going to be saving a lot of healthcare spending that we have already, as well as having a much healthier population. And so some of the other opportunities are we have one of the lowest uninsured rates right now. We have a growing dependence on mobile and tech. We also have a shortage of primary care physicians. We have persistent health disparities that we are only starting to address now, and trying to hack solutions for it. We are now just starting to focus more on value-based healthcare. The ACA and other health policy changes much rapidly, and changes really rapidly every single month. But there are a lot of areas of opportunity within those changes. And then lastly, stakeholder initiatives to reduce waste. And so, we really have to make sure that the stakeholders within this intersection understand the opportunities, but also understand the challenges that we have. So we're all sort of collectively working towards the same goal. And so when I'm asked by an investor or even other stakeholders about public health, or when I ask them about it, rather, the response I usually get is, that's the government, right? And so my response is, well, yes, but it's not the only it's not the only area public health is active in. Public health is active in policy, in community, in organizations, in interpersonal relationships, and definitely within the individual. These are all areas. Public health spans all of these areas, and so does the tech that supports it. So, when public health tech, we're seeing solutions that span across the entire socio-ecological model. So it's not just government, it's not just policy. We're going to be hearing soon from Eric and Healthify, who's going to talk about some of the other areas that population and preventative health operate in, or the opportunities for those areas too. But we really have to be thinking about the entire ecosystem of the individual, and not just their relationship with access to care. And then, so finally, what are some of the solutions that we can talk about when it comes to improving population and preventative health, at least from a startup's perspective or a digital health perspective. And some of the low-hanging fruit is that we really need to make sure that we are diversifying the teams that are building these solutions. So in the Valley right now, this is what our tech workforce looks like. It is about 62% white, it's about 30% Asian, and then African Americans account for 3%, and then Latinx is only about 5%. So we don't really have a ton of diversity in terms of the teams who are building solutions, our tech solutions these days. So that's something we really, really need to address. And why is this important? It's important because studies have shown, this is a McKinsey analysis that shows that you do have much better outcomes and better performance when you have diverse teams. And so when you have gender diverse teams, so when you're making sure you have equal amounts of female and male team members, it's about a 15% likelihood of outperforming those that aren't. And then when you're talking about ethnically diverse teams, that jumps up to 35%. And so the data is out there that diversity is a good thing. It's a good thing for society, but it's a good thing in terms of how we build our solutions and how we walk through the thought process of thinking about solutions. And so I'll end by saying, for us who are working in public health tech, and so therefore thinking about communities and the diversity and variety of communities that exist in our country, to have that diversity, that lived experience built into the product development process is absolutely critical. And so to the extent that we can do that by including them on the teams, or including the patients in the product development process and the solution process, I think we are going to have really good tools coming out of digital health and public health tech, and ones that are going to have lasting outcomes, pretty positive, large positive and lasting outcomes. And so I will close to that and pass the ball on to Eric, who will talk about Healthify. And if anyone has any more questions about what we do, or wants to get in touch with us, please contact us. And we are also at p2health.co is our website.
Great. Thank you, Marquesa. And I will, before I pass it over to Eric, just a reminder that if you have any questions, please feel free to write them in the chat box. Once Eric's done, we'll start taking either audience questions, or I have some questions of my own if we don't get anything from the audience. So please ask your questions. And let me introduce Eric Connor with Healthify.
Great. Thank you, Megan. And thank you, Marquesa, for your wonderful presentation. I want to work in a few elements that you touched on into my own to talk maybe a little bit about piloting and why that's important and how you can build upon that as a success. I think that's an excellent point. And I'll try to talk to that as I run through my presentation here. So just to give everybody a little bit of a flow of what we're going to be talking about, I'll give you a little bit of background on Healthify and why our mission statement is there's more to health than healthcare. And then I'll talk a little bit at Marquesa's prompting to talk about who we work with, pilots and research, and then I'll just get into a little more the problem we're solving around social and behavioral determinants of health, and then how our solution works, and then what we're doing to integrate our solution with existing healthcare IT, like the electronic health record, which I think is really important with the new meaningful use requirements coming out, but just the general transition within healthcare to value-based care and how we can make better, more informed decisions by integrating social determinants into the patient record. And then, of course, I can also talk a little bit about healthcare regulations and how we take those very seriously right from the start, everything from HIPAA and HighTech to the compliancy and other issues at hand. And I just lost the screen for some reason, Megan. Okay, it's back. Great. So what does Healthify do? So we aim to integrate the social determinants of health into the care delivery system. So when I'm talking about social determinants, I'm sure I'm preaching to the choir here because we've all heard about social determinants in the last few years. I joked before 2007, nobody was talking about it. After 2007, nobody will shut up about it. So I really feel like I'm consistently beating on the horse of social determinants. But when we're talking about social determinants, we're talking about issues like food insecurity, substance abuse, domestic violence, mental illness, this whole gamut of needs, litany of issues that affects certainly the 72 million Americans now enrolled in Medicaid, but also the several millions more of Americans who still go uninsured due to living in states where they are either too poor to qualify for the exchange, but are now too wealthy to qualify for Medicaid. So those tend to be the highest utilizing demographics of emergency services, frequently due to unaddressed social and behavioral health issues. So we try to provide a little more context around those social health needs to the clinician, to the social worker, to the case manager in a practice. This is a quick little data point that we collected from over 9,000 care managers and community health workers who use the Healthify platform. Marquesa had a great statistic there. I think she said it's about $260 billion in economic loss because of preventive needs. Robert Wood Johnson Foundation has actually attributed around $85 billion of that to Medicaid alone, and within Medicaid due to these 40% of health outcomes that are related back to social and behavioral determinants of health. So it's a large chunk of that puzzle. And I'm sure, as many of you know, Medicaid beneficiaries are the highest utilizers of emergency services, even more so than the uninsured. Often it's found when individuals first enrolled on Medicaid, they frequently go to the emergency room more because it's the first time that they have insurance. And they're often going because a lot of these issues that you see here are unaddressed. So what the care managers and community health workers using Healthify have identified is around those top 50% of needs, around a quarter is related to food, another quarter related to housing. If we were to map this on Maslow's hierarchy of needs, we're looking at the second tier of the pyramid there. So this is really, really basic stuff that's frequently going unaddressed for many millions of Americans. So if you're a healthcare provider in the audience, you've got your work cut out for you, particularly if you're dealing with a large Medicaid population. And I'm sure you can probably relate to a lot of these issues firsthand. And as you can see, the other 50% is a fairly unsurprising distribution of other needs. So what does Healthify do to try and address this problem? Well, first thing first, we're typically working with Medicaid managed care organizations and patient-centered medical homes, and now Medicaid ACOs, and in certain states where they've adopted the health home model, health homes as well. So it's everything from managed Medicaid down to safety net providers. And one of the big, most immediate things we're trying to do for them is to take the amount of time it takes a case manager or a community health worker to make a search, to make a referral on behalf of a patient, which can range anywhere from 10 to 15 to 20 minutes, and try to get that process of finding services, referring for services, and tracking referrals down to just 2 or 3 minutes, allowing case managers and community health workers to spend more time working with their clients to build the trust that's often necessary to provide services, to focus on some of these higher level issues to reduce ED readmissions, and to really target improving outcomes and reducing disparities caused by social determinants over time. And then some of the ancillary stuff that we do, of course, is contextualizing all of this information for reporting, so you can really look at how social determinants affect your patients writ large. And that provides a lot of value, especially if you have to report back to CMS. And if any of you in the audience, I know Georgia, if you're in Georgia, you unfortunately were not allowed to apply for the Accountable Health Communities model, which would have allowed you to perform a fair number of system transformations to actually coordinate care directly with community-based partners. But if you're calling in from another state, perhaps your organization did apply for the Accountable Health Communities model. CMS will be announcing the winners of that later this year, and I wish you a lot of luck, because that's releases several millions of dollars in funding for system transformation to begin doing a lot of this work at your organization. And if you're coming from a patient-centered medical home, 2014 guidelines got at social determinants in an ancillary way, but the new 2017 guidelines are going to heavily focus on social determinants. So we're slowly seeing this creep into the healthcare space. So that's very, very exciting. I've talked about this a little in the solution, the use case. I'm a staff member. I log into Healthify. I can find services, make referrals, and associate that with the patient record. But a lot of the benefit in being able to do this is being able to tie this information into the electronic health record. The meaningful use, stage 3 in 2018, there's a big focus on interoperability, information exchanges, and of course, patient engagement is always at the top of the list. But also, we advocate for bringing psychosocial information into the electronic health record, whether that's through a standardized, pre-validated assessment like the PREPARE assessment. And if anybody is not familiar with PREPARE, it's put up by the NACHC along with conjunction with the Kaiser Family Fund and a few other organizations who put that together. And that's the protocol to respond to and assess patient needs, risks, and experiences. And that's a really good tool for collecting standardized information on patients. And that's something that we frequently integrate into Healthify as well. And then you can push that information into the electronic health record. So when we're collecting information on social determinants in Healthify and making referrals to community services, what we're typically doing to make the entire process easier for a clinician or a provider is to integrate with the EHR. I don't think anybody's ever said easy and EHR integration before, so this might be a first, but there are some benefits to it. Taking the HL7 ADT message from a health record like Epic or NextGen We can auto-provision patient records in Healthify for the case manager, social worker to access. And then whenever you do these interventions in Healthify, you can send information in an ORU HL7 message back to the EHR, allowing you to store some of the psychosocial information and activities related to community referrals in the health record. And this right here is actually a screenshot of a sandbox test of an integration with Epic EHR and where Healthify and a lot of its information reside. Unfortunately, you'll find it's easier to integrate in later health record models. Like I believe this is Epic 2014. Some of the earlier models, they don't even have a space for it because that's not what they're designed for. But the health record is beginning to catch up, and I think the requirements around meaningful use are also pushing health record vendors in this direction. So it's a really exciting time to be working in the social determinants and psychosocial space.
All right, thank you, Eric. Great presentation, and actually before, I guess I will go on to this slide, but we are going to move into Q&A now. So, I think one of the things that I kind of heard or I was thinking through for all of your presentations had to do with data. And, Dr. Mack talking about data really from that clinician standpoint and what is happening and what is being exchanged between physician and patient or physician to physician. Eric, you really talking about that bridge between within the clinical setting and then the social services organizations that are out in the community, and Marquesa really working towards investing in the workforce and getting those skills that make the data actionable. So really I would like for you all to kind of provide your own perspectives on where we need to go with kind of getting to Marquesa, that endpoint of making the data actionable. We hear from a lot of our providers, and one of the audience questions that we have today talks about how the physicians don't know what to do with all of the data that they have now that we have gone predominantly electronic. So just your thoughts on where we're going with that and what we need to do to really get that data more useful. Great, and I think that's a good transition over to Eric, because I know that's what you guys are trying to do at Healthify, is turn some of that data into useful information for the physician.
Yeah. So I mean, I think that a large part of what we're trying to do is provide context and an easy way to access and find this information. So when we're looking at our platform holistically, it's taking information from psychosocial assessments, standardized, pre-validated tools, contextualizing that information, distilling it down to recommended service programs that a case manager or social worker can go through, click through, use to find and generate resource recommendations, referrals, make those referrals, update the patient record with that, and then taking all of that information together, sending it back into the electronic health record. Or sending it into a data warehouse of some sorts so it can be used to look at reports. And ideally what we'd like to do is start tying this really back to emergency room readmissions because I think you'll see that there's probably correlation, and certainly research that Robert Wood Johnson Foundation has come across or has conducted has indicated that housing, for example, is probably one of the, or an unstable housing situation is probably one of the biggest predictors of emergency room readmissions. So there's a lot of that. So. And thank you for whoever just shared a bunch of info on social determinants in the chat. That's a great link.
Well, I was just looking at those and wondering what those were. Great. So yeah, Marquesa, your thoughts on that?
Come up in the tail end. Yes, definitely. So yes, absolutely. I mean, I think the type of data that company like Healthify and companies like Healthify are gathering are really painting a picture of the patient when they leave the doctor's office, and that actually accounts for upwards of 80% of their health outcomes. And so, to touch on the housing issue that Eric brought up. In Alameda County, I just learned this actually at Health 2.0 this week, that in Alameda County, the biggest threat currently to public health is lack of housing, or the inability to afford housing in the Bay Area. I don't think it's any secret to anyone that we've experienced soaring housing prices. There is not enough housing for the amount of people coming into the city or into the area, and for those that are living here too. And so to the extent that, we can include folks that have gone through this process, a painful process, those that have worked in the community, or, other organizations very close to the community into the product development process, we'll be able to identify first the right questions and then start building the right solutions for it. You can't expect, wealthy, man that's gone to Stanford and Yale. That is literally who makes up, our tech teams right now in the Valley, to even know where to start thinking about innovating for low-income communities or community in rural Louisiana. Or for Native American communities, it's not possible. And so, what I mean by bringing in that lived experience into the product development process is that you literally have to bring people onto your teams, and so that's something that we're really trying to do here in the Valley, is just increase our diversity. And it starts with early stage startups like Eric's company. It's much harder to move a large ship when you've reached the enterprise level, like an Apple or a Google.
Right. Well, and I think that's such a great point that was really important in your presentation about that, the impact of a diverse workforce and how much that impacts the performance, and the fact that you're working with a lot of the universities and trying to get these ideas out there to those students at a young age, and we're doing a lot of that STEM and pipeline work here at Morehouse School of Medicine too. So thank you for that work. So a lot of you talked about policy within your presentations, but just want to, because we are the policy center, I wanted to ask you a specific question about kind of what are the policies that drive your work? Are there specific policies that either federal or state level that you keep an eye on, or those that you're really seeing as kind of the door opener incentive for getting your work out into mainstream?
Yeah, so I have two big ones that immediately come to mind. One is the Accountable Health Communities model, which is an innovation model that CMS put out. And the other is the 1115 waivers that states are applying for DSRIP, the Delivery System Reform Incentive Payments. I think New York State is actually doing some of the most innovative work around DSRIP. And I believe California is resubmitting an 1115 waiver to mimic some of the changes that New York State has done, particularly around the creation of performing provider systems and the integration of community and social services into the healthcare delivery network.
Yeah, this is Dominic. I guess it's an opportunity to talk a little bit about MACRA. I think MACRA policy, which actually began to affect providers in 2017 and significantly in 2019, really affects our target population of smaller practices and hospitals. I think it's an opportunity for us to improve health outcomes, and when it comes to the technology, it's an opportunity also to implement new technology within these smaller practices and all practices. CMS is putting some money out there with a grant that a number of folks on this call probably recently applied for, that will provide technical assistance to those providers. That should be announced in November. Again, it's going to be a yeoman's job to try to take these practices over the hump, but I think those policies, of course the macro policy, but also the policies to put more money out here to help, and really with the innovation that Marquesa and Eric is talking about, more money, the federal government has to put more money toward these policies that help to encourage these type of tools that are innovative, but also help these communities as we're speaking of.
And I'll give an example of sort of where policy and public health collide, or innovation for public health tech collide, and that's with gun violence research. So, Congress has essentially forbidden us to federally fund gun violence research. California took a stance just earlier this year and actually decided that they were going to fund their own gun violence research center. So that started earlier this year. But as most of you know, gun violence is one of the biggest causes of death here in this country. And so it's a huge public health issue. And so for us not to be able to study it and to be able to inform policymakers on how we can make our cities safer, it's a detriment to everybody's health, and it holds back innovation, really great innovation that some of these really amazing entrepreneurs could be coming up with today around containing gun violence.
Thank you for that example. One other policy that we really proud of came out of Georgia. The Department of Public Health has put together their State Health Improvement Plan proposal, which we had the opportunity here at NCPC. We reviewed it, and social determinants of health were all over it and addressing health disparities, a lot of discussion on that, and improving maternal and child health outcomes. And it's definitely a really exciting initiative that our state is taking on. And, technology will definitely be playing a role and is mentioned in the plan as well. And we provided some feedback, just, thanking them for recognizing those issues. And so that was, that's an example of one here in Georgia that we're working on, and looking forward to see that advancing as well. And in that note, we did have a question from an audience member on how can state public health officials assist in the efforts of your work, and have you seen a lot of support from a state level in reaching positive health outcomes? So love for you to provide your own perspectives from your respective states.
Well, in Georgia, definitely we really work hand in hand with, as I stated, the Department of Community Health and also Department of Public Health to try to address the technology, but also the health and the healthcare issues. In the state of Georgia, we are restricted. Eric talked about, we weren't able to apply for certain funding because of his relationship with ACA. And I think in the Southeast, that's pretty prominent in some of the, Southeastern states because of the political influence, and everybody has their opinion about that. But I would say the people within those organizations, public health, everything related to public health in Georgia and across the Southeast, are really trying to do what's best for the people. Some things are out of their hands, but we've really been able to partner in the state of Georgia with public health, and we're partnering now around telehealth and some other issues, and of course with the Department of Community Health, we continue to work around health information technology and implementation around the state.
I think for us there's been some interest, more so from county health departments, but every once in a while a state health department will reach out, interested in learning more. But there have been no official policy moves at the state level for or against social determinants in our experience. Aside from applying for, like 1115 waivers for Medicaid.
And I'll say, although P2 Health works across the country in every state, I can speak for California. So the California Healthcare Foundation has been great at sort of helping to bridge the gap between public health and tech. They've been super supportive in promoting innovation centers and entrepreneurs, and really making the call for more entrepreneurship within public health tech. It's an intersection that has not been spoken of, although there is a lot of activity going on. I think it's something that actually needs to be pulled off from the rest of digital health, so it doesn't kind of get bogged down amongst the wearables and all the other, sexy digital health niches that are out there. But really making a case for more entrepreneurship and for more digital health support. So mobile and other tech support for specific public health topics like social determinants of health.
Great. Thank you so much. So unfortunately, we are about out of time. I do want to encourage the audience to reach out to our speakers. And we are all on Twitter. So for those in the audience that want to reach P2 Health, their handle is at P2 Health. And for Healthify, it is at Healthify US. So please feel free to engage with us on Twitter. I know we didn't get to some of those questions that were still in the chat box, so we will try to follow up on some of those in the follow-up emails. And just to let everybody know, we will have another webinar in November or December. We don't know yet when the final rule for the MACRA legislation will be coming out. It is supposed to come out in November, so we'll take probably a week or two to do some analysis. But for those of you that were online for the proposed rule webinar, we will follow up on some of those provisions. So thank you so much for joining us today, and have a good afternoon. And thanks to our speakers, too.
Thank you, Megan, for putting this together.
Thank you, guys.
Thank you.
Definitely. Thanks, Megan.
Thank you.